center and empower in all our region. Some specialties are here not performed or not present in all over Egypt, especially in our center and pediatric oncology session. One of them a very nice talk and informative talk. Thank you.
Thank you, Dr. Muhammad. Good morning, everybody. On behalf of my colleagues, I'd like to welcome you, really welcome you. We are very happy to have you with us. Professor Peter Fasching is an eminent professor of obstetrics and gynae. You will be, you feel that it's very strange for us, but breast cancer in Germany, which is not known for us, is one of the eminent, accepted, yes. And he was one of the eminent co-investigators in the group of Destiny trial evaluating the new drug TDXT, which will be our focus today in the situation of breast cancer. I think it's a very good situation to have you with us today, and I think we will have a fruitful day. Thanks, Professor Peter Fasching, for your visit to us. And I invite the chairpersons to come to the meeting.
Revolution of antibody drug conjugates in metastatic cancer management.
Thank you very much. First of all, sorry for being late, and apologies because seeing all these patients here, I already have a bad conscience that you're here and not with the patients, so apologies for that. When I'm traveling a lot, you know, the first impression that I got when I entered this hospital, because I'm traveling so much, and I've been traveling quite a lot. So you see cancer patients everywhere on the planet. It doesn't matter whether they're rich or poor, doesn't matter which religion, doesn't matter which age. It concerns everybody. Patients is united in the fight against cancer, so I appreciate you here. Let's get through this quickly so you can get back to your patients. Okay. So, talking about the presentation, because you said about this center, and you said very nicely the city of Erlangen. I'm not from there, I'm from Cologne, but I work there. It's a very small city that has rural patients from northern Bavaria. We serve about 1.5 million people. It's a large university hospital. The city of Erlangen, though, might be known more from big companies like Siemens. So global headquarters, Siemens is there. If you have an X-ray machine of them, an MRI or a CAT scan, they are screwing that together in that city. Like there's a production like this. So everything goes to that city. Or if you like a Puma and Adidas shoes, there's also global headquarters in that city. So that's where I'm from. So if you meet somebody, they work there, work there, work there, or work there, but there's not much more. It's only work. So today we're going to focus on a little bit on drug development and then turning to these new ADCs, the antibody drug conjugates, that will change the way how we think about treatment of cancer and how we think of treatment of future cancer treatment a lot. So in this slide, I tried to summarize how we've been thinking about drug development for the last 20 years and even the future. So here in the middle, that's what we've been doing already for the last 20 years. It's been a long time ago that these subtypes of breast cancer have been described. It was actually in the year 2000, so a long time ago. And since then we've been trying to characterize the breast cancer patients in these subgroups. Triple negative, HER2 positive, we switch that pathway off. PI3 kinase inhibitor treatment, for example. The pathway is active, let's switch it off. And let's hope that the cancer is treated by switching this active pathway off. And lots of developments have been coming out of that. The PI3 kinase inhibitors, the BRCA pathway inhibitors, even denosumab, the RANK inhibitor, is from that thinking. Switch off an active pathway. They play a role in cancer. So, and then turning to the last box down here, that's what we're going to talk about today. For an antibody to find it and then release the substance or the mechanism that treats the cancer cell. And that's, for example, TROP2 ADCs, so anti-HER2 ADCs, but also anti-HER2 CAR T cells or NK cells. There's been trials for low-expressing HER2 sarcomas that have been treated with CAR T cells. So it's a change in principle that the pathway doesn't need to be active anymore. So if we talk about the anti-HER2 ADCs, and today specifically about trastuzumab deruxtecan, we have to think now about two tumor entities. It's HER2 positives, as we know it clinically, and also HER2 low expressing tumors where there's some kind of expression, but we do know biologically the tumor antigen, PD-1, neuratinib, TDXD, tucatinib, mirvetuximab, and there's even more that are being in clinical development right now. What has that done? So first, I always like to show this initial paper from 1987 from Science, one of the most prestigious medical journals, and I always talk to the young resident that the genetic alteration, it's not expression. What they described was that the copy number variation, so usually every cell has 2 copies of the gene. That's normal. It comes from your father, from the mother, but if it's more, we call that amplification, because for the first time, the genetic alteration was associated with the worst prognosis, basically starting a genomic era of medicine, thinking about that genetic alterations can and have an influence on the cause of the disease. And trastuzumab, of course, was developed in the next 10 years, being approved in the late 1990s for metastatic breast cancer, doing actually 2 things: blocking the pathway, and secondly, attracting natural killer cells, what's called antibody-dependent cell-mediated cytotoxicity, or ADCC. There's 2 mechanisms how the trastuzumab works. One has an immunological aspect with the natural killer cells, and the other one is blocking the pathway. So it's a very smart mechanism how to address the treatment, and that changed how we were thinking about HER2-positive breast cancer. When I started working, to tell a patient that she would be HER2 positive was a very, very bad message, because the prognosis in early breast cancer was as bad, the 2 Kaplan-Meier curves down here, as triple negatives. But after the introduction of trastuzumab, that changed, and now it is not the worst prognostic subgroup anymore. And in metastatic cases, it's even more dramatic. It was the worst prognostic group, as you can see here on the left, and now on the right, you can see it's now the best prognostic group in metastatic breast cancer. But I started working when we had to tell the patient this bad news, and now we tell the patient this good news. This someone is HER2-positive breast cancer, and we can actually treat it. What does it mean for the treatment? In most cases, and I see that you have lots of patients, so from that perspective, from a working doctor, if patients with metastatic breast cancer that are HER2-positive come to you for the first time, a lot of them are de novo cases. In Germany, it's 50%, I don't know how it is here, but the HER2-positive patients first time metastatic, 50% from them are de novo. It's only half of them that have history of early breast cancer and recurrence. Many cases come metastatic and are treated for the first time in the metastatic setting. So when you have 2 treatments here like trastuzumab and brackets trastuzumab, it's only applicable for about 50% of the patients in Germany. In that first time metastatic setting, the standard would be trastuzumab, but might not be necessary yet because it's an untreated patient, but usually the standard should be trastuzumab, and in second line, up to the TDXD, TD1 would be second line, but now because of the DESTINY-Breast03 study, TDXD is the standard in the second line, and the TD1 now moved to the third line, and after that, anything is possible because there is no guidelines concerning that. I don't have to show you the Cleopatra study. I hope in Egypt nobody takes offense of the study name. Obviously, it was a very popular name for that study. It introduced the pertuzumab in the metastatic setting very nicely. That's something that we've seen until recently only in HER2-positive studies. PFS, progression-free survival benefit, would in almost all of those studies translate in overall survival benefits. So very satisfactory to see the these new very effective drugs, always with both PFS and OS. But remember the curve of the left one, the Kaplan-Meier curve. It's not that we heal the patients. Most of them have a progression in the end. As you can see, the Kaplan-Meier curves go down. So the big question was, because TDM1 and pertuzumab were developed at the same time in parallel studies. So there was no data about sequencing, even if in most guidelines pertuzumab would be considered the standard in the first line, and TDM1 in the second line. There was absolutely no data about the efficacy of TDM1 after pertuzumab, or the other way around, if you wanted to start with TDM1. So from real-world data, that's where registries become quite important. This data is known, as you can see here. The formulas have been negative, the PFS time is only 3 to 4 months. And that matches the experience from the clinical practice. Putting a patient on TDM1 after the first-line treatment usually results in a very, very short progression-free survival time. So high medical need how we can improve that situation. The TDM1, just quickly as a reminder, that was not after pertuzumab, that was after the trastuzumab therapy mainly. Again, a very nice difference in progression-free survival and also in overall survival. Again, this very nice translation here as results into overall survival benefit. But this is now not done very often anymore, second line, because the TDXD, of course, is more effective. But very nicely, with the TDM1, new principle for study design was introduced, what we call post-neoadjuvant treatment. We do know patients that do not achieve a PCR after neoadjuvant therapy in any kind of subtype, they have a very bad prognosis, while patients where the tumor disappears completely have good prognosis. So the question was, can the TDM1 introduce not achieving a PCR? So that's established. But again, already challenged by a destiny B05 study where TDXD is compared to the TDM1 in that situation. I ask you to remember the shape of the Kaplan-Meier curve with the PFS. That we have these advancements doesn't mean that not almost every patient progresses finally with the HER2 positivity. So it's very important to keep on working and find better substances that help improving the therapeutic situation. And try to summarize that on the slide. How can ADCC be improved? What about the hormone receptor crosstalk? How immune oncology improvement? There is mutations in HER2, PI3 kinase mutations, but the improvements recently made mainly focus on drug distribution and HER2 expression. And this leads us to the improvement of the antibody-based treatments. And on the slide is a little bit shifted, sorry for that. So focus on it's a cartoon. On the left side, that's supposed to be trastuzumab, like just a regular PAR. And to understand what's happening is that these engineers are working on how can we improve the antibody that it works much better. That's I think very advanced technology and very still not well understood things for us doctors, because it's a very new technology, and while we accept and we welcome that these drugs work very well, we still don't understand very well what can be modified to make them even work better. Which modification lead to what side effects, because now we have to deal with a very distinct profile of side effects that are very important to take care of. But the knowledge is there. There are experts that can modify this antibody. And now, in the next few years, we have to see how this can modify the way that works and the way it produces side effects. Very simplified, they use a linker with which they combine the antibody with a payload, usually any kind of cytotoxic substance, usually a chemotherapy, but also other substances. And then now we already can see that depending on the kind of linker and the kind of payload, this antibody will behave differently. And you can not only do one on there, you can put 3 on there, or 5 or 10, or how many, whatever can be manufactured. So let's focus on these 2 antibody drug conjugates, because you can see how there might be a difference in how they work. You have the antibody, and then there's a chemical binding between the antibody and the chemotherapy. And in the case of the TDM1, this is a very strong binding. It binds very strongly together, and it's not easily released from each other. So the antibody first needs to be internalized into the tumor cell, and then it needs lysosomal processing before the payload is being released from the antibody and can do its effects. And in case of the TDM1, this binding is not that weak, it's not that strong, it's a little bit weaker. So this chemotherapy is released easier from the antibody, and maybe already before it's entering the cell, it can work in the surrounding area. And you will hear of the word bystander effect, that's what people call bystander effect. And you see all these charts, and somebody tells you a nice story about it. I like to show you something else because for me it's easier to understand. It's a preclinical experiment, and I will not torture you with lots of that stuff, but it's worth focusing and understanding what's happening here. So what these researchers have done is they manufactured a tumor out of two cell lines. They put together a HER2 positive cell line and a HER2 negative cell line together. So a tumor was formed with these two cell lines. You can see here the blue dots are the cell cores of the HER2 negative cell line. And the brownly stained parts are the HER2 positive breast cancer cells. There's two breast cancer cells in the HER2 positive, HER2 negative. And in the middle, they're treated with TDM1, and on the right side, they're treated with TDXD. And you can see here in the middle, the TDM1 beautifully removes the HER2 positive cells. And that's what we would expect. The antibody binds to the cancer cell, it's going into the cancer cell, it's an on-spot delivery and kills the cancer cell. While in that case, we have on the right only fatty tissue and a blood cell, and a blood vessel that is left. So it's also the HER2 negative cells that are gone. So why is that? And now you can come up with your own ideas why that happens. But it's clear that the chemotherapy of the antibody is not only working in the HER2 positive parts of the cell, of the tumor, but also nature this bystander effect. And there's lots of researchers that work on this bystander effect and why it's happening and how it's happening. But for me, these are stories. I like that picture that I just showed you so you can have your own ideas about what's happening because it's not well understood what this bystander effect is. So let's go into some data with all the things that are not known, what is known, and that's a fact. It's working really, really, really well. And the study that first showed that was the Destiny Breast 03 study that was presented by Javier Cortez first in ESMO, and the last update was shown by Sarah Velvetz, who presented the updated data with a much longer overall survival follow-up. So just to remind you, Destiny Breast 03 study focuses on clinically HER2 positive cases. So that's what you classically would consider HER2 positive, for indicating trastuzumab. And these patients were required to be previously treated with trastuzumab, either in the metastatic setting or, if they were treated in the adjuvant setting, needed a quick recurrence. So the study wanted to select for patients that have a kind of trastuzumab resistance. And these patients would then be treated with a TDXD and the TDM1 in a randomized way. And of course, overall survival is the most important thing, so I'm going to show you that first. But it's important to see that both are included, hormone receptor positive and hormone receptor negative, 50-50 about. And there is a reasonable number of brain metastases in here, about 15%. And with regard to the prior therapy lines, most of the patients got one prior therapy line, but also 60% of patients got 2 or more therapy lines. So in my opinion, that's a pretty heavily pretreated patient population. So usually there's not much to expect in that population with regard to progress. But this is the overall survival data. And I show you that first because I think it's always important to save people from dying. It's the most important thing to be happening. And that study showed it could do that. After 2 years, there's a difference of almost 8% absolute difference between the two randomization arms. 8% of patients less dead after 2 years, and that I consider a big success. And this is subgroup analysis where there was no subgroup where you would think that's a subgroup I don't want to give the treatment to. That's always how we should look at the subgroup analysis. And that's the Kaplan-Meier curve that you remember maybe because it attracted lots of attention. And for the breast, I specialize in breast cancer, for us breast cancer doctors, we were always jealous of in a conference you would go around and you would have people working on lung cancer and these big differences in a new substance. Or the prostate people that had like big differences for progression-free survival, and in breast cancer we never saw that. So that was the very first time through the introduction of a new treatment you would have such a big difference in progression between the two Kaplan-Meier curves with a hazard ratio of 4.33, something was never seen before. So truly there was lots of enthusiasm at that time about the treatment. When I see all your patients down here, you talk to them about progression or the probability of dying, that doesn't mean a lot because either you're dead or alive, so what does it mean to the patient? In the clinics, when you use it, that's for me the most important picture because it's the response rate. And when you start treating patients with a TDXD, what you truly see and what you learn is that this treatment leads to a tumor response. So it's very motivating for both patients and doctors to have a treatment where you have a high confidence and a high chance that when you start the treatment that you actually can see a treatment response. Because as you can see here on the upper left, the blue ones, these are the ones treated with TDXD. There's just a very few number of patients, like less than 5 where we didn't see a response to that treatment. Okay, so everything comes at a cost, and we will talk about with the next study about the ILD and the pneumonitis. And in that study, there was 0. So why am I showing you that? If there was 0 pneumonitis effects, because doctors were very trained already at that time how to take care of that. So when this drug was developed in the beginning, interstitial lung disease was associated with a relevant number of deaths. So there was a concern about the development of this drug because if you produce a relevant number of the side effects, and even one ILD will keep you busy in the clinics for a long time. If a patient is really bad and has to go to intensive care unit and is possibly ventilated, that case will keep you busy, regardless whether it's only one or a few months. It's something that should be avoided. And it can be avoided, or it can be maximize the chance that it can be avoided. As you can see in that chart, there were 0 interstitial lung disease cases in that study. Okay, so Germany, the data was quickly implemented in the guidelines, as you can see here. After the first line treatment, TDXD is recommended with a double plus. That's the highest recommendation rate we have in Germany. And it's widely used now these days in patients with HER2-positive disease. As I mentioned, this new way how we think about drug development is not bound to the subtype. So even if it's an anti-HER2 antibody, now we design the trials that a little bit of expression might be good enough to deliver the target to the cancer tissue, or even the cancer cell, but use the presence of a HER2 receptor to get this antibody somewhere in the tumor tissue, and then it should release the payload and create the therapy effect. So we also have to concern with the HER2 positive, hormone receptor positives that have a low expression of HER2, or the HER2 negatives that might have a low expression of HER2 in the last 50 years. And when I put that slide together, I found it amazing that tamoxifen, which is the cornerstone for the endocrine treatment for a long time, was introduced in 1977, so it's just 3.5 more years. It's a 50-year anniversary. This was used for such a long time, saving so many women's lives. It's an amazing drug. Of course, we have more effective drugs now with the aromatase inhibitors that were introduced in the 1990s and the SERDs. The fulvestrant, just to remind you, fulvestrant, the SERD, was approved more than 20 years ago. Now, with the new substances, the substance class was used for breast cancer for more than 20 years. And then here, you see the series of drugs where you do combination therapies trying to overcome endocrine resistance. And remember, this is from the thinking if a pathway is active, let's block it and see whether it can help treating the disease. And these substances are everyone's paroxysine, glyphosate, alpelisib, and there's more to come, like capivasertib, which was recently published in the New Journal of Medicine as being very effective as well in hormone receptor positive breast cancer. And then there's these yellow ones in there that are now also available for hormone receptor positive breast cancer despite not being endocrine treatments. And these are PARP inhibitors for germline mutated breast cancer cases, the olaparib and the lazoparib, also in the adjuvant setting, the olaparib, but now focused here down on the TDXD and the sacituzumab govitecan, which are two antibody drug conjugates that work in hormone receptor positive and triple negatives, both. This is just to show you that the ESMO guidelines, because of the efficacy, quickly implemented the recommendation of those. You cannot bring that back there. I cannot even read that here. I know, I just know the slides, so I can tell you. This is the trastuzumab deruxtecan up here, already very early in the treatment of metastatic breast cancer. After a quick progression, the trastuzumab deruxtecan are indicated for later therapy lines in hormone receptor positive breast cancer. This slide is the same everywhere around the planet. What are our recommendations? Don't do chemotherapy before you exhausted all endocrine treatment options. That's the guidelines everywhere. I'll tell you a secret. We doctors in Germany were very bad at that until the introduction of the CDK4/6 inhibitors. So we found out through real-world registries that up to the CDK4/6 inhibitors, we would treat 40 to 50% of the patients first time with chemotherapy. Didn't trust the endocrine treatments for some reason. I don't know why. It was just that we needed the data from the CDK4/6 inhibitors that all are very good at overcoming endocrine resistance in a relevant number of patients. You can see that the Kaplan-Meier curves in the beginning, where with the monotherapy it goes down, and then with the CDK4/6 inhibitor it goes that way. You can see exactly the percentage of patients in which endocrine resistance is overcome. All of these substances here. So about 50 to 54 months, 1 year longer with the CDK4/6 inhibitors. And that's something that we haven't seen in a long time. I'm responsible for education of the fellows and the residents. So now they think there's overall survival study every year. You know, they think, oh yeah, it's moving good. But as a matter of fact, it was last time the study was overall survival, it was gemcitabine. 2004 or 2005, and now we have like overall survival study every year. So young doctors getting a little bit spoiled, thinking it's overall survival benefit every year. But CDK4/6 inhibitors was the success so good that now chemotherapy use in the first line setting, and that's down here, went down from 40 to 50% to 10 to 20%. So that's already a big success. There's a trust in the endocrine treatment, but that shifts the problem in after CDK4/6 inhibitors and focus on the right side, because that's the treatment sequences for the first line setting, second line setting, and third line setting. And while in the first line setting, the biggest bar here is CDK4/6 inhibitor, you can see that the treatment path that's most frequently used is that one here, and that's CDK4/6 chemo. So instead of giving chemo in the first line setting, now it's given like more and more in the second line setting and the third line setting, despite, of course, treatment options are available like CDK4/6 after CDK4/6 or alpelisib or everolimus or monotherapies. But the most popular sequence is CDK4/6 chemo, and that was for me like in fourth line, I think it was fourth line, who told me what is the chance this chemotherapy works. And you know what you say. You say, yeah, there's a chance it works. I don't know whether it works. We have to wait and see. Let's try it. And the last one didn't work, so this one will not work either, right? And as a matter of fact, she's right. I mean, especially in hormone receptor positives, if there's already been a treatment of 2 chemotherapies that didn't work, the likelihood that the next one will work is very, very, very low. I mean, I can remember maybe 1 or 2 cases in my career where you had a tremendous response after like 2 failed chemotherapies, but that's pretty much it over the last 20 years that I remember. So, you know, having something that works better than the chemotherapy in hormone receptor positives would be a great success to have, and the ADCs actually fulfilled that. And now thinking back is these are HER2 positives. The pathway is active. You have a bad prognosis. And there's these HER2 2+ cases that are not having an activated pathway amplification. But also, and you cannot see that very well here on the projector, but the one must also have some kind of the 2 expression. So the idea is, let's use